Hello, I'm Paul Peterson. At the thought of the phrase heart attack, many people conjure up the stereotypical image of a man with an agonized look on his face, sweating heavily and complaining of crushing pain as he clutches his hand to the left side of his chest. But a woman having a heart attack is just as likely to have pain in her jaw, her neck, arms, right chest, upper back, or upper abdomen. She could be nauseated, have trouble breathing, or be totally exhausted. When a woman experiences these symptoms, she is very likely to dismiss those feelings or attribute them to stress. Since heart disease in women is difficult to diagnose, has varying symptoms, and is more deadly than in men, women need to learn more to stay heart healthy. The fact is, according to the American Heart Association, heart disease is now the leading killer for both women and men. This program will examine the differences and causes of heart disease in both genders, the warning signs, and will discuss prevention and treatment. Please stay tuned for Aging in LA. A recent survey shows that only 3% of U.S. adults practice all Big Four habits to help prevent heart disease: eating a healthy diet, getting regular physical activity, maintaining a healthy weight, and not smoking. Cardiovascular disease is widespread and includes all conditions that affect the heart and the blood vessels. Many risk factors are associated with cardiovascular disease. Most can be managed, but some cannot. The aging process and hereditary predisposition are risk factors that cannot be altered. Until age 50, men are at greater risk than women of developing heart disease. Although once a woman enters menopause, her risk of heart disease triples. Today we will explore the differences and causes of heart disease in both men and women. Welcome to our first guest in this part of the program, Dr. Howard Hodes, Professor of Medicine and Preventative Medicine and Principal Investigator of the Early versus Late Intervention Trial with Estradiol at the Keck School of Medicine, University of Southern California. Dr. Hodes is heading a landmark study that will try to confirm that women who are given estrogen soon after menopause will be better protected against heart disease. Thank you so much for joining us, Dr. Hodes. There were some amazing surprises when we did the research for this show, and I think most surprising was that we thought the studies for menopausal women were a done deal, that information was pretty solid. But can you update us with some of the latest findings of therapy for postmenopausal women?
Sure. Well, what we've known for a very long time, well over 40 studies called observational studies, had very consistently told us that women who took hormone therapy versus women who did not had less cardiovascular disease and less cardiovascular death.
Okay.
Then in 2002, a large study called the Women's Health Initiative was published. This looked at a combination medication called estrogen and progestin, specifically Prempro. And what was found was that at the end of that study, in the first report, that the women who actually took the Prempro, or the hormone, actually had a significantly higher rate of cardiovascular disease than women who did not.
Wow.
So as you can imagine, this was a shocker to most in the field. What became more apparent over time was when the data were looked at more closely and the data were fully adjudicated, this significant level that we look at in biology and medicine actually did not exist any longer. And this was a publication that occurred a year later. Wow. This did not get the press that the original publication got.
Isn't it always the way? What do they say? A lie goes around the world 8 times before the truth puts its shoes on?
I guess. But the problem was that there was more of a rush to publish the data before all the data was what we call fully adjudicated or fully looked at and determined if those heart attacks were actually real heart attacks or not. And when they really got the data completed, it was clear that this was not a significant effect.
I see.
And then 2 years later, with the estrogen-only arm of that study, it was clear again that there was overall no benefit, either harm or good, in terms of heart disease reduction.
Well, some of the reporting I recall actually said that there were some risks associated with the hormonal therapy. Are those factored into this kind of new way of thinking? Because this is black and white, it seems to me.
Well, there's different risks to look at with hormones because it has a systemic wide effect. The most current literature that's now evolving, at least with estrogen only, these risks are very small. In fact, they're considered rare risks. For example, breast cancer with estrogen only was actually found to be reduced rather than increased. This was out of a study looking at 16,000 women funded by the NIH. When it came to strokes, which is also another big concern with hormones, it was found in women less than 60. That risk was 1 per 10,000 women treated. So a very, very small risk. And in fact, these risks are no greater than the risks seen with many other medications that are given for prevention of heart disease, such as lipid-lowering drugs and aspirin.
I see. Now, you brought along a couple of slides that I think are pretty interesting because people need to know how you measure the relative efficacy, if you will, of treatment. And if we could, let's put one of the first slides up. Tell us what we're looking at, please.
Sure. This is a non-invasive study. It's ultrasound, which I think women are really quite familiar with. If they ever been pregnant, they've had ultrasound done of the fetus, the unborn baby. And this is a technique we could use where we could actually visualize the wall of the artery in the neck. And as shown here, it's called the common carotid artery below. The ultrasound waves go through the jugular vein and they bounce off that far wall, as you can see in the lower image.
Yes.
And we can actually measure that very precisely.
The thickness of it. I see.
And that thickness tells us how much atherosclerosis or hardening of the arteries there is. And what we propose or hypothesize is that with the hormone therapy, that wall will thin over time. Now, I could tell you in a study we published approximately 5 years ago, we indeed did see that. And this was in women of an average age of about 63, 64.
Right.
This new study is to look at younger women within 6 years of menopause versus women who are 10 or more years beyond menopause, to help settle this issue of whether hormones are effective in younger women versus older women.
Well, this is really important. With women dominating the senior demographics because of their longevity, this is going to impact millions of women.
Correct. I'll give you an example. In the studies from the Women's Health Initiative, it was found that the hormones actually reduced the new onset of diabetes mellitus. And if you carry out the predictions of the reduction in the number of events that occurred, the number of women that developed diabetes, we're talking at any one time, if we take the current number of 40 million postmenopausal women now, we're looking at a lifetime reduction of about 12 million cases of diabetes mellitus. So the numbers are really quite staggering and large, because if you look at the number of women going through menopause yearly, which is about 1 million women per year now in this country, these numbers really translate into a very large degree, especially with heart disease, because women who have diabetes are at great risk for heart disease, and more than 80% actually die from cardiovascular disease that do have diabetes.
Well, now, heart disease, as I said in the opening, this really is the whole cardiovascular system, isn't it? It's
correct.
Because you can have ailments far removed from the heart where there can be difficulties, and diabetes being one of them.
Correct.
So how do you measure the entire circulatory system beyond what we saw there with that kind of slide? Is it blood pressure? Is it that simple to be checked regularly?
Well, I think when it comes to prevention, certainly blood pressure is a very important measurement to know and have reduced if it is elevated. This is especially so in women because there are very few interventions that actually work in women in preventing heart disease. And one of them that we know clearly is a reduction in blood pressure, keeping that blood pressure normal. And there are plenty of studies now that support this. So it's very important, especially blood pressure. The other way to look at vascular health in an indirect way, if you will, is body weight. Women are at at greater risk for heart disease than are men who are overweight. So we need to be sure that women are down at their ideal body weight or as close to that as possible.
I got you. Wow. Well, what are some of the other preventative steps that women can take? Are they the traditional things that we should be applying? Well, we know about but don't apply, like nutrition, for example, exercise?
Right. So the way to maintain one's body weight, obviously, is eating an appropriate diet. That includes calories as well as the components of those calories, the amount of fat, the amount of cholesterol, and also the types of fat, whether it's saturated and monounsaturated fat, polyunsaturated fats, trying to avoid the transsaturated fats, which everybody's heard a lot of over recent time.
Boy, have we ever.
And including exercise with all this, because combined, that's the most powerful way to get body weight down and to maintain it at the ideal weight.
Well, so many of our seniors really do struggle with an alteration in lifestyle for beginning an exercise program because there are risks associated with that. Particularly, I'm worried about falls and balance issues. So best idea to sort of talk with your primary physician and actually chart out a program?
Right. I think that's a great recommendation, absolutely. Because every individual is different, and whether you have heart disease or don't have heart disease, whether there's problems with balance and vision issues and hearing issues, you're absolutely right. And I think that that person, whether it's a male or female, should be consulting with their physician on what an appropriate exercise program may be for him or her.
Well, seniors, sometimes there are just amazing stories of the turnarounds that seniors have been able to affect in their lives. Have you seen that in some of your studies, women who have gotten the message and went, I'm going to change this, and boy, did they change their lives?
Oh, absolutely. I think that once there is good follow-up and interest by whomever, it doesn't have to be even a physician, but somebody in the field of medicine, it could be a nurse practitioner. Once the idea is that there's somebody helping me and watching me and getting me the help I need, whether it's with diet or exercise, there is a lot more compliance, and we see a lot of women in particular, because those are the kind of studies we're doing now, lose phenomenal amounts of weight and become in shape again and reduce their heart disease risk.
Right, and that makes the rest of life go a little better. Stress levels are suddenly lowered, but I, of course, like the idea of finding the support group to help you, not just medical professionals, but it may be, the gals you play cards with. And I think that's an important overall consideration. Doctor, it's time for a short break, but thanks to our guest in the first half of our program, Dr. Howard Hodis, Principal Investigator of the Early versus Late Intervention Trial with Estradiol at the Keck School of Medicine, University of Southern California. When we return, we'll be joined by another expert in heart disease, Dr. Gerald M. Pohost, Chief Medical Officer of the Salic Cardiovascular Centers, an organization that provides diagnostic services and treatment for cardiovascular disease. We'll be right back after these important messages.
I remember when Dad used to help me. Boy, how things have changed.
Yes, I need to make an appointment for my father, Jose Alvarez. Right. Hey, listen, I'm going to be late to that meeting. I got to take my dad to a doctor's appointment.
It's really hard juggling my career with the needs of my dad.
Well,
I sure wish Mom was here to help. I can't do it alone.
The Department of Public Works Bureau of Contract Administration keeps the city's projects on track, ensuring safety first and fairness always, from the streets all the way to the stars.
Welcome back to Aging in LA. Our topic today, heart disease, the differences in men and women. Welcome to our guest in the second half of our program, Dr. Gerald M. Pohost, the immediate past Chief of Cardiology and Professor at the USC Keck School of Medicine. He was recently appointed as the Chief Medical Officer of the Salic Cardiovascular Centers, which is an organization that provides diagnostic and outpatient treatment facilities. He is also principal investigator of National Institute of Health grants dealing with diagnosis and treatment of heart disease. Dr. Pojos is a member of the board of the American Heart Association. Welcome, Dr. Pojos. Thank you so much for taking the time to join us today. I was amazed by the statistics I heard of the impact of heart attack on women as they grew older. How did this come about? Is it just because we're living longer, we're suddenly seeing this dramatic rise?
I think we're living longer, and we had wrong diagnostic parameters for women. When the Framingham study was done decades ago, all they used were men to figure out how to make the diagnosis of heart disease, pre-heart attack and heart attack. Women were not participants in this study.
Wow.
So,
see, this is one of those things, a lot of men made this decision, I'm sure.
well, men thought that the incidence of, or the funders thought that the incidence of heart disease was really much higher in men than it was in women.
Isn't that something? Wow, and yet here we are today, and the women's risk has not only increased, but it's almost age-specific, post-menopausal.
Absolutely.
It's going to increase dramatically.
And in fact, by some tallies, it's exceeded that of men.
Wow. Now that's really amazing. Is that associated with some of the other aspects of being female, weight issues, having had and reared children, those kinds of things, those factors in there too?
It is.
Wow.
Hormonal factors.
Now you mentioned just briefly about some of our diagnostic tools. This is an amazing new world we have with some of the most extraordinary medical machines. It's like a dream world. It's science fiction, isn't it?
It is.
What are some of the various tools that we can use to help diagnose heart disease and the potential for heart attack?
Nowadays, there are several diagnostic imaging types of approaches. You heard Dr. Hodes before. He talked about ultrasound.
Yes.
Ultrasound to make measurements of the thickness of the wall of the artery to determine how much atherosclerosis, or to predict how much atherosclerosis there might be elsewhere, including the carotids, which are these vessels in the neck.
Okay.
So ultrasound is a very important approach. It is largely two-dimensional and can give you cross-sections of the heart, of vascular structures. And it's also very much less expensive than the other technologies.
Right. Well, but that's an important consideration.
It is.
I mean, if there isn't a gigantic factor where you need to know, it's a good opening gambit, but there's more down the road, isn't there?
But about ultrasound, it can be portable. Some people think they can construct an ultrasound system that will ultimately be the size of a stethoscope. So a doctor would go in to examine a patient and flip his stethoscope or her stethoscope to the ultrasound mode and be able to see the motion of the heart and the thickening of the heart and all of the functional criteria we use to detect heart failure, for example.
Wow.
That's something to think about in the future, and it's coming. It's coming. The next kind of technology, and I'm really listing them in the order in which they appeared and became successful, was that of radioisotopes. We call it nuclear cardiology.
Right. Yes.
And the radioisotope that is most commonly used to detect heart disease, especially disease involving the coronary artery, atherosclerotic disease of the coronary arteries, is called thallium. A lot of people have heard of thallium.
Yes.
I was watching a mystery show the other night, and if you give enough thallium, it's also poison.
Right. Well, that Russian woman just in the news recently, and her daughter had the thallium poisoning.
So,
but now this really lights up.
Lights up the heart.
The blood vessels of your heart. Right?
And it's given in such a small dose that it could never have any effect like the Russian.
Well, that's good to know.
So I don't want anybody to be worried about it, but it's an excellent tracer, and it's called a tracer because we give it in such low concentrations, but it's radioactive and we can see it. So you give it intravenously, and you give it intravenously during exercise, and it shows the way the blood flows to the heart. So if parts of the heart are supplied by arteries that are narrowed, those parts will get less thallium. If they're supplied by normal coronary arteries, then those parts of the hearts will look normal and bright. So a darker area will mean that there's ischemia or significant reduction in blood flow compared to the normal part, which would be bright.
Right.
Using the thallium scan has been a fantastic way to make the diagnosis of significant heart disease, and really adds to the coronary angiogram, which is the gold standard. That's when we use a catheter
Right.
and thread it up through the one of the arteries, inject the contrast into the coronary artery, and then film it using X-rays or either digital or celluloid film.
Right. Now these are done though in real time now, right? I mean, this is like watching a movie of
Exactly.
of the working parts of our body.
That's right.
That's fantastic. It's just
It's remarkable. and
amazing.
It's just the tip of the iceberg. The future is unbelievable. But
Well, magnetic resonance imaging, MRI. I've actually done that. It was. I know for a lot of people it's kind of claustrophobic. In fact, you brought along a couple of pictures for us
Yes,
to take a look at. Well, here we are. I mean, that machine can be kind of intimidating, frankly.
it can be. It's large. You have to get into a rather narrow bore. But nowadays, the length of the tube that you have to get into is much shorter. So your head is frequently, at least it can see everything outside of the head part
Yeah.
of the head direction.
Gotcha.
So the claustrophobia is much less of a problem.
Now, this is a pretty sophisticated piece of equipment. Its resolution scale is pretty neat these days, isn't it?
It's very impressive. It has a very high resolution. It can image in 3 dimensions.
Oh, is this, for example, one of those images that
It
you
is.
might see?
It is. That's a picture of a cross-section through the heart. And on the uppermost chamber, there are 4 chambers.
Right.
There's the uppermost, which is the right ventricle. There's the second one, that's on the right-hand side. And then there's the second level, which is on the left-hand side. That's the right atrium. And then we come down a notch to the 2 chambers on the bottom. And they're the left ventricle on the right and the left atrium on the left.
Now, trouble strikes most often where? In the blood supply to the heart?
Yes. In the blood supply.
But we've heard about valves as well. Right?
And valves as well. And you can see this is actually a 3-dimensional reconstruction using magnetic resonance images that show the vessels. You can see the vessels that go to the lungs. There are a lot of vessels that are seen on the right and the left-hand side. And then there are vessels that supply the left ventricle, which is the red chamber, meaning that it has redder or more oxygen containing blood within it. So it's that chamber that we're really mainly concerned with, but still the right ventricle also can have a problem with the blood supply.
Now, what would be the differences between men and women of the same age? Let's say, well, we discussed for seniors, but are there significant differences of, say, a 70-year-old man, 70-year-old woman?
Well, maybe I can talk just for a moment about a study that I've been involved in, and from which a manuscript published in the New England Journal was resulted. And that is the WISE study, the Women's Ischemia Syndrome Evaluation, which looked at women with heart symptoms that underwent coronary angiograms, meaning that they had to go to the cath lab and have a catheter put in and then dye injected. That's what we call an invasive procedure.
Yes.
And then we did MRI on these women. And what we found, we do several kinds of MRIs. You can do imaging and show how well the heart's beating. You can show the same thing that you show with thallium, and that is how well the blood flow or how adequate the blood flow is to the heart muscle. And you can also show how metabolically active the heart is. And the metabolism of the heart depends on this very important chemical, a high-energy phosphate called ATP. People have heard of ATP.
Yes.
It stands for adenosine triphosphate. But there are other high-energy phosphates. The other one that's very important is called phosphocreatine. Well, if we take phosphocreatine, we'll call it PC, and look at it relative to ATP, if somebody has reduction in the amount of blood supply to the heart, an inadequate amount of blood supply, the phosphocreatine, PCR or PC, will decrease, and the ATP will stay the same unless they have a very severe reduction. What we found in a series of women is that over 20% of women that went to the cath lab had no diagnosis, were told they don't have any disease, go home, don't worry about anything, you'll be fine. Many of them came back.
Mm-hmm.
And what we found was that over 20% of those women had a finding which indicates that they actually had heart disease.
How can that be?
Well, we believe that it's due to the fact that they have heart disease involving the blood vessels that you can't see on a coronary angiogram. They're called the microvessels, so small that they don't show up on a standard coronary angiogram.
I'll be darned. Wow, I'm sorry, that's all the time we have for today's episode of Aging in LA. Thanks to our guest in the second half of our program, Dr. Gerald M. Pohost, Professor of Medicine, USC Keck School of Medicine, and Chief Medical Officer of the Salix Cardiovascular Centers. And thanks to our guest in the first part of our program, Dr. Howard Hodis from the University of Southern California Medical School. Remember that cardiovascular disease is the #1 cause of death for both men and women in the United States. But there are ways to beat the odds by recognizing the risk factors and doing something about them. Quit smoking. Stay clear of secondhand smoke. Eat lots of fruits, vegetables, legumes, whole grains, fish, and avoid fatty food. Make sure, of course, that you get regular exercise. And see your healthcare provider to find out if you have problems with high blood pressure or high blood levels of cholesterol, triglycerides, or glucose. And you know, a daily dose of laughter may be good for the heart too, because like exercise, it makes the blood vessels work more. While depression can raise the risk of dying from heart disease, studies have shown that average blood flow increases 22% during laughter and decreases 35% during mental stress. So, laughter is definitely the best medicine. The Los Angeles Department of Aging produces this program with CityView, Channel 35, so that seniors living in Los Angeles and surrounding communities are well informed on the many issues that face them in everyday life. And also to let you know of the many services that the Department of Aging offers our senior citizens. Now, we'd like to hear from you with comments on the program, what you like, what you think can be improved, and ideas for future programs. Please give us a call. The number's on your screen, 213-252-4088. That's 213-252-4088. Call us with your comments and ideas, and we look forward to hearing from you. I'm Paul Peterson for the Los Angeles Department of Aging, the people here at CityView, Channel 35, and all of our guests on Aging in LA. Thank you so much for watching. We'll see you next time.